Hello everyone, I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. In this session, I'll be doing a quick recap or review of this important topic, that is adrenal insufficiency. So, adrenal insufficiency, it is the disorder which is characterized by decrease in adrenal cortical hormones, right? Decrease in adrenal cortical hormones. Now, what are the various types of adrenal insufficiency? This adrenal insufficiency, we have what is called primary adrenocortical insufficiency. What do you mean by the word primary adrenocortical insufficiency? It is the disorder where the pathology is in the gland. Right? It is the disorder where the pathology is directly in the gland, and that is called as the Addison's disease. Then we have the secondary adrenocortical insufficiency. Secondary adrenocortical insufficiency is that the pathology is at the level of the anterior pituitary gland. Right? The pathology is at the level of anterior pituitary gland, wherein there is decrease in the ACTH levels. Right, wherein there is decrease in the ACTH levels. That is called as secondary adrenocortical insufficiency. So primary is pathology is directly within the gland. Secondary, the pathology is at the level of the anterior pituitary. Now, what is the primary adrenocortical insufficiency? See, in case of primary, as I have said you, the pathology is directly within the gland. There will be decrease in the adrenal cortical hormones. What are the adrenal cortical hormones? That includes the aldosterone. Next, there will be decrease in the steroids, and there will be also decrease in the weak sex hormones. Right? There will be also decrease in weak sex hormones. So this is what is your primary adrenocortical insufficiency. Then you need to know what is the etiology which will cause the primary adrenocortical insufficiency. So the most common cause of the primary adrenocortical insufficiency, it is the autoimmune mechanism. And autoimmunity is the most common cause of primary adrenocortical insufficiency, mainly in the industrialized or the Western countries, where the autoimmunity is the most common cause for the primary adrenocortical insufficiency, which is also called the Addison's disease. Then followed by that, what is the most common cause of primary adrenocortical insufficiency in India? In India, the most common cause is the tuberculosis, right? That is a very, very important point. Now, what are the other causes of the primary adrenocortical insufficiency? So apart from tuberculosis, the next important cause will be surgical removal. What are the clinical scenarios where you will do surgical removal? Like for example, if there is any tumor of the adrenal gland, like in case of adrenal adenoma or bilateral adrenal hyperplasia. So once you do a surgical removal of the tumors, the individual may land up in adrenocortical insufficiency, which is called Addison's disease. And infections like tuberculosis and then fungal infections. Now, what are these fungal infections which will cause primary adrenocortical insufficiency? That includes histoplasmosis, right? And then followed by that, the viral infections. And these viral infections include the cytomegalovirus. So these are the infections which will cause the adrenocortical insufficiency. Then followed by that, we have hemorrhagic conditions which will cause adrenocortical insufficiency, trauma, and as well as the metastatic invasion. So these are all the other causes of adrenocortical insufficiency apart from autoimmune conditions and tuberculosis. Then the metabolic causes. See, metabolic failure in hormonal production is also one of the very important cause for Addison's disease. And apart from that, secondary to congenital adrenal hyperplasia, wherein the individual may develop adrenocortical insufficiency. Right? Next. Having discussed about the various systemic causes, you need to know what are the drugs which will cause the adrenal insufficiency. So we have an adrenolytic agent. And what is that adrenolytic agent? That is metotane. Metotane, in fact, it is used in the treatment of the Cushing's. Right? In fact, it is used in the treatment of Cushing's, and that can cause the adrenocortical insufficiency. Then Followed by that, what are the clinical findings in the Addisons? So if you take the clinical findings in Addisons, let me tell you, there is weakness, paresthesia and cramping. Why is that they have this? Because corticosteroids are not there, metabolism of the food substances does not occur, metabolism of carbohydrate, protein and lipids does not occur. The energy acquisition is not there in the individual, due to which they will have weakness. And then they will also have intolerance to stress. Why? Because the steroids are not there. And personality changes such as irritability and as well as the restlessness. So these are some of the clinical findings in patients with the Addisons. Now, what are the features of the chronic disease? In chronic disease, let me tell you, these individuals, they have the small heart, weight loss, and there will be a sparse axillary hair. These will be the features of the chronic disease. Then, why there is hyperpigmentation in Addison's disease? So in Addison's, there is decrease in the corticosteroids. Right, in Addison's, there is a decrease in corticosteroids. So once there is decrease in corticosteroids, there is increased ACTH production from the anterior pituitary. And along with the ACTH, parallelly, there is also release of the MSH, that is melanocyte stimulating hormone. And that is the one which will make the individual, so there is excessive production of MSH. And because of this excessive production of MSH, there is hyperpigmentation in the individual. And this particular hyperpigmentation, it is diffuse, that is throughout the body, and it is brown or tan in color or bronze darkening of both exposed and unexposed parts of the body. That is what is the hyperpigmentation what you have in the Addison's disease. Then you need to know why there is arterial hypotension in patients with the Addisons. See, in patients with the Addisons, the steroids are not there to improve the vascular tone. Steroids, what they do, they will increase the sensitivity of catecholamines for the action on the blood vessels. Steroids are not there, and at the same time the aldosterone deficiency is there, so due to which the individual will land up in the arterial hypotension. So arterial hypotension is seen, and it is often orthostatic owing to lack of effect of cortisol on vascular tone, right? Next, followed by that, you need to know what are the gastrointestinal abnormalities in Addisons. The gastrointestinal abnormalities in Addisons, they include weight loss, nausea, vomiting, diarrhea, and as well as the abdominal pain. So these are the gastrointestinal abnormalities in Addison's disease. Then followed by that, we have a very important endocrine emergency that is called Addisonian crisis. What is Addisonian crisis? It is abrupt decrease in the adrenal cortical hormones. And this Addisonian crisis, it could be secondary to some infections. And what will be the presentation of this Addisonian crisis? They present with fever and as well as very severe hypotension. That is what will be the features of the Addisonian crisis. Then in adrenal crisis, fever, vomiting, abdominal pain, altered mental status, and vascular collapse may occur. These are the features of the Addisonian crisis, right? And very important point, there will be abrupt decrease in the adrenal cortical hormones. Now, what are the etiologies which will cause the Addisonian crisis? The etiologies which will cause the Addisonian crisis, that includes number one, an individual who had undergone surgical resection of the adrenal glands. Then infection, serious infection like tuberculosis or histoplasmosis, and major stress. These are the etiologies which can make the individual to land up in Addisonian crisis. And in children particularly, we have a syndrome called Waterhouse-Friderichsen syndrome. Now, what is this Waterhouse-Friderichsen syndrome? It is the clinical condition where there is acute adrenal insufficiency. And this acute adrenal insufficiency, it is secondary to the adrenal hemorrhage. Right? It is secondary to the adrenal hemorrhage. So that is what is your Addisonian crisis. Right? That is what is your Addisonian crisis. Then what are the other causes of the Addisonian crisis? The other causes of Addisonian crisis include bilateral adrenal infarction or hemorrhage, and patients who is abruptly withdrawn from chronic glucocorticoid therapy. These are the other causes of the Addisonian crisis. Now, what are the electrolyte abnormalities in Addison's disease? The electrolyte abnormality that you will encounter is there will be high potassium levels. Now, why there will be high potassium levels? Because there is decrease in the aldosterone. So, because there is decrease in the aldosterone, the potassium is not excreted out, and that will result in the high potassium, and as well as there will be also low sodium. A low sodium with high potassium levels and mild acidosis, this will be electrolyte and as well as metabolic abnormalities that you will have in the Addison's disease, right? Next. Now, what is the definitive diagnosis in Addison's? The definitive diagnosis in Addison's is the co-syntopin test, right? What is this co-syntopin test? This is also called an ACTH stimulation test. So what you have to give is, you have to give an ACTH analog. And what is that ACTH analog? That ACTH analog is a co-syntopin. And after giving this co-syntopin, you need to test for the steroid levels. So after giving co-syntopin, there should be increase in the steroid levels, right? There should be increase in the steroid levels. If there is no increase in steroid levels after giving co-syntopin, that tells that the individual has landed up in the Addisons. Okay, next. So there should be a brisk rise in cortisol levels after the co-syntopin administration. If there is no rise, that is suggestive of Addisons. And what are the laboratory findings in patients with the Addisons? So if you take the complete blood picture, in these individuals, they will have neutropenia, lymphocytosis and eosinophilia. Why is that? Because the steroids are absent, the steroids are reduced. Steroids, what they are immunosuppressive agents. That means they will suppress the number of lymphocytes. They are anti-allergic. That means they will suppress the eosinophils. Now here steroids are not there, so your lymphocytes and as well as eosinophil count will be elevated. And they will cause the neutropenia. There will be neutropenia in patients with the Addisons. Then there will be elevated serum potassium levels. Why there will be elevated serum potassium levels? Because of the deficiency of aldosterone. And there will be low sodium. That is also due to deficiency of aldosterone. There will be low sodium. And there is also low blood glucose levels in the individual. Why there is low blood glucose? Because when steroids are not there, there is no hepatic gluconeogenesis. And that is the reason why there is low blood glucose level within the individual. And there is low plasma cortisol level. That is the characteristic feature of the Addisons. So these are the laboratory findings in Addisons. Now, you need to know what is the differences between the primary and as well as the secondary adrenal insufficiency. See, in case of primary adrenal insufficiency, that is, there will be decrease in steroids, right? There will be decrease in mineralocorticoids, that is decrease in aldosterone, right? And there is also decrease in the weak sex hormones. Right, there is also decrease in weak sex hormones. So that is what is your primary adrenocortical insufficiency. Whereas in secondary adrenocortical insufficiency, there is only decrease in steroids. Aldosterone levels, they remain normal. Right, aldosterone levels, they will be normal. And there will be decrease in the weak sex hormones. So that will be the story. Right, that will be the story in case of the secondary adrenocortical insufficiency. So these are the prime differences. So clinically, how are both different? Hyperpigmentation. Hyperpigmentation is just seen only in case of the primary adrenocortical insufficiency. You don't have the hyperpigmentation in secondary. Secondary, in fact, you have the hypopigmented skin. And this hypopigmented skin, in case of secondary adrenocortical insufficiency, this is called as the alabaster skin. Right? This is called the alabaster skin. Next, followed by that, yes. So you see this flowchart. You take any adrenocortical insufficiency, these will be the manifestations: weakness, hypotension, weight loss and hyperpigmentation. But particularly this hyperpigmentation is seen in case of the primary adrenocortical insufficiency. So whenever you are suspecting the Addisons, you need to do the ACTH stimulation test or cosyntopin test. You need to give 250 micrograms of cosyntopin intramuscularly or intravenously. Then you need to test for the plasma cortisol levels. After 30 to 60 minutes, you need to check for the plasma cortisol levels. For suppose there is subnormal response, then you have to check for the ACTH levels. If the ACTH levels are high, that is primary adrenocortical insufficiency. If the ACTH levels are low, it is secondary adrenocortical insufficiency. Now the point is, why in case of primary there is high ACTH levels? See, because of reduced steroids that will inhibit the negative feedback mechanism, or there will be excessive production of the ACTH from anterior pituitary in order to synthesize the steroids. So that is the reason why there is high ACTH. And in secondary, the problem is directly within the anterior pituitary, and that is the reason why you have the low ACTH levels. And what about the aldosterone? There will be subnormal or aldosterone increment in primary, subnormal. But whereas in case of secondary, the aldosterone levels will be absolutely normal. Why is that? Because the synthesis of aldosterone is dependent on the RAS mechanism. That is the reason why now your aldosterone synthesis from adrenal cortex is nowhere dependent on the ACTH. That is the reason why in patients with secondary adrenocortical insufficiency, they will have normal aldosterone levels, right? So that is how you will differentiate primary and secondary. Now, how do you manage this Addison's disease? See, in patients with Addisons, you have the hypotension. So you need to give the fluids, right? You need to give the fluids. And along with that, right? Along with that, you need to supplement the steroids. And which particular steroid you need to give? You need to give the hydrocortisone. Why is that you have to give hydrocortisone? That is because the hydrocortisone, it has the mineralocorticoid activity and it also has the steroid activity, right? It has mineralocorticoid activity and as well as the steroid activity. So that is the reason why you need to give the hydrocortisone in Addisons, because in Addisons there is decrease in mineralocorticoid, there is decrease in glucocorticoid, and there is also decrease in the weak sex hormones. So you need to give a drug which has dual activity, which has the mineralocorticoid activity and as well as the corticosteroid activity. And what is that particular drug? That is the hydrocortisone, right? That is hydrocortisone. Then what is the drug of choice in case of the adrenal crisis? And it is the same drug, that is you need to give hydrocortisone and along with that you need to rapidly administer the fluid. Why is that you need to rapidly administer the fluid? Because the individual has the hypotension. And what will be the route of administration of this hydrocortisone? That is intravenous route of administration. That is how you give the hydrocortisone. Next, what is the drug of choice for secondary and even tertiary adrenocortical insufficiency? So for secondary or tertiary adrenocortical insufficiency, you need to give dexamethasone, right? Why is that you want to give dexamethasone? Because dexamethasone is the drug which has the potent steroid activity, right? Dexamethasone is the drug which has the potent steroid activity. In case of secondary adrenocortical insufficiency, the aldosterone levels, they are absolutely normal, right? The aldosterone levels, they are absolutely normal. Now because the aldosterone levels are absolutely normal, you should not give a particular drug which has aldosterone activity. You have to give the drug which has only the steroid activity. And what is that? That is your dexamethasone. So this is about your adrenocortical insufficiency. Only your primary adrenocortical insufficiency is called Addisons, right? The remaining secondary is due to pathology at the level of pituitary. Tertiary is due to pathology at the level of hypothalamus. With this, I will wind up this topic. Thank you very much.